must admit that many of you who are so keen on therapeutic horticulture or horticulture therapy or nature therapy must have a lot more in-depth knowledge and insight than I do, because I studied as a research topic. I also try to learn more about HT. I engage in horticultural therapy studies a few times with my students and with my other colleagues for a number of projects. And I also taken a course on basic therapeutic horticulture. So that's my background. But then I would enjoy our discussion later so that you can share with me your insight. Right? Okay, let me share my slides. Can you all see my slides, please?
Yes.
Yeah, great. Excellent. Okay, hold on for a second. All right. Okay, this is, first of all, a declaration of conflict of interest. I have nothing to declare. And this would be the outline of my talk. First, I need to talk about my search strategy because of the topic is related to a synopsis of evidence. So the basic search strategy would be important. That's what I'm going to begin, right? The findings and then the appraisal of the evidence is what I'm going to talk about. And then I'm going to summarize the findings and have a little bit of discussion on the way forward, which would carry through to our final section of Q&A time, right? Now, some glossaries, horticultural therapy, therapeutic horticulture, and PLWD would be people living with dementia. It used to be PWD, people with dementia, and now it's more respectful, trying to say just people living with dementia. Sorry about the spelling. Quality of life, all right, QOL. And then SR, systematic review, RCT, randomized controlled trial, quant and qual represent quantitative or qualitative studies, and ROB is risk of bias. I have explored with the Trans Foundation about the potential audience. I know some of you may be from the academia and some may from the general public. So I'm going to speak to a broader audience. So that, pardon me if you're already an expert researcher, that I'll be just bringing about some very elementary research concepts. So please bear with me, right? Nowadays, I think it is fine to conceptualize knowledge and the expansion of knowledge as being like a sea of wealth of knowledge. And it is just almost impossible to understand what is being published in the literature because it is increasingly exponentially. So it'd be more manageable if we could just examine a bucket of water, right? So in world of what the literature is like nowadays, it's not possible to just review each and single paper. So unless it is a funded project, given a couple of years, like two years at least, to go through it carefully. Otherwise, it's purely impossible to do that in a very systematic way. So I'm just trying to examine here the systematic reviews, all right? Now, I've been invited to speak on a similar topic by the for Association of Therapeutic Horticulture in Hong Kong. So last year, I have done my searches, right? So I did a PubMed Central using the advanced search mode. I used the keyword horticultural therapy or therapeutic horticulture in title and abstract search. I use garden or gardening, and then I use effect, okay. And then with this combination, I didn't put in a year limit, okay, no year limit. I found 9 systematic review and 1 longitudinal study. And of course, I always updated my searches, and this is up to this year. up to, oh, sorry, okay. I pressed the wrong button, okay. Okay, all right. So up to this date, and I found two new systematic review, and including one from 2014, right? I don't want to exclude that. And I also use Google Chrome because sometimes I think search engines are pretty effective in searching, and they may include those not in the database, because database, they use keyword search. And it depends on how a librarian or how the researcher would try to use the keyword to label their paper. It may not be searched, all right? So I use Google Chrome, and then I use the AI mode with specific instruction to check for accuracy. And this is the question I asked: do we have solid evidence about the effect of therapeutic horticulture or horticultural therapy and gardening? And I specify into the last 10 years because I don't want to be inundated with all the data that may not be useful. Okay, so I found 4 other systematic review last year, but this year I found 3 new review papers. But this year I also polished my searches to include some other things. What did I include? I include the word health and well-being and not just effect. And so I want to expand a little bit and see if I have missed out anything in the past. And I found 3 other systematic reviews not included earlier, and 1 study that is longitudinal in design. And this is my total, okay, just to give you a background of what I did. So altogether, 23 systematic review and 2 longitudinal studies. And this is what it's like. It's a bit wordy. Don't worry about it. I'm going to go through them systematically, all right? I just wanted to show you the overall picture of what this review are, so you can refer to it. I group it in reverse chronological order. All right, I use different color system to denote different populations. So this yellow brownish color is about general population. I put it in quotations because although the authors didn't specifically mention particular population, but if you look closely, they do include some particular patient categories, such as patient with depression, anxiety, etc., etc. But I try my best to group it into the category that's most suited what they are characterized themselves as. Right? So this is for older adults, and this is longitudinal design. And these are for specific groups, mostly dementia, schizophrenia, depression, okay? And only 1 systematic review on school children. Now, I'm not going to tell you all the 23 systematic review one by one. That'd be very boring. I'm happy to share my slides. So I'm going to go through a few of these slides and explain what I've seen, what they have reported, and how would I praise them. And so that everybody got an idea what this is. And then going to the summary part and the discussion part. So this is the first slide on Wang and Burrows, published very recently last year, is gardening on health of adults with chronic illness. So although it seems general, it is in fact including a lot of people with multiple problems like pain, obesity, anxiety, depression, hypertension, etc. And the purpose is to investigate the effect of gardening-based training or horticulture therapy on physical, mental, and general health. So this is the database that they've searched. Okay, a database, which is pretty much, and then they examine the RCTs or quasi-experimental studies. Now, quasi-experimental studies are similar to RCTs in that they examine the cause and effect of certain intervention in relation to the outcomes of the cause-effect study. The only difference that they have is that a quasi-experimental study do not randomizely allocate participants. So that is the big difference between them. Now, they found 23 studies which have a sample of 4,535 participants, mean age 54, and female 63%. So what are their reported findings? Gardening-based training program have a small to medium effect on mental health, and relatively small effect were found for physical health and general health. Okay. Now, my comment on the study is that it is problematic to combine RCT with a single group before and after study, okay, of gardening related intervention program, because you can never be sure of the results because the allocation of participants are not random, okay? They have a broad definition of chronic condition and health, and therefore the statistical analysis would be combining diverse outcomes, and that could be problematic too. Now, this study is published in the open access mode, and so that we can use one of the forest plot. The figure is called a forest plot. Okay, they're reporting the result. Within this paper, they have many different reports like this, figures like this. So let's just briefly talk about this, how to understand them. This is the line of no effect. So here, this study, first study that's mentioned across this here, has no effect. Now, this is the confidence interval of a point estimate. So this point is the estimation of the study on the effect. And because the confidence interval is so large, we can never be sure because the correct finding can be anywhere within this confidence interval, all right? So the narrower the confidence interval, the more confident you can be about the result. And so here, we can look here, favors experimental, favors control. So if this is the poor result, pooled, right, like all the combined results. So this is the point, these are the points, various points, this is the combined results. If it falls on here, it means it's favor experimental. If it falls on here, it means that favor control condition, okay? Another thing we need to look at the forest part is the I-square. Okay, I need to remove this as well. Okay, hold on for a second. The I-square here. Right. So you can see that I-square, we can accept the I-square. I-square is an interpretation of the sample heterogeneity. Okay, so 50% we can accept, but 89%, that means the sample are highly heterogeneous. So doubtful, okay. Now, this is another way that researcher would explain or evaluate the credibility of findings reported in the paper. Grade, GRADE, which means grading of recommendations, assessment, development, and evaluation. And it's the same study that we're talking about now, okay? So we look at these parameters that they report. Now, inconsistency, it is about the unexplained heterogeneity that we talked about earlier. Directness refer to the PICO, the research question. Okay, so whether they're pinpointing their analysis to answer the research question, that is directness and indirectness. The imprecision is that how close are the estimates. So we talk about the confidence interval, all right? And then the publication bias. Most journals, from many years until up to date still, they publish only paper with positive outcomes. And not just the journal editors, but also the authors, researchers, If they have nothing to report or negative result to report, of course, they don't want to present that. Okay, so there's a tendency to publish what's only reported or found to be positive. So that is what we call publication bias. But nowadays, we're getting more publications that report negative results, right? Now, this is what Wang and Burrow reported. Our result revealed an estimated 31% reduction in mental health issues with the gardening intervention group compared to the control group, with an estimated mean difference of 24 and 4% for general health and physical health, respectively. So more in mental health, right? This estimates was slightly lower than those reported in previous meta-analysis. So the authors are commenting on previous meta-analysis report much higher, 42% difference in psychosocial well-being between the gardening and the control group. So this is what they have been reporting. Okay. Now, another study by Pentiro et al. And team, okay, and gardening on well-being and mental health and quality of life. This is an umbrella review, okay. Umbrella review is review of systematic reviews. I'm reviewing systematic review, but I'm not doing umbrella review because I'm not following the methodology. Most of the time, I'm pretty conservative about interpreting umbrella reviews because a systematic review, if it's done correctly, is very informative. If it's done in a poor manner, then it's not credible. And then if an umbrella review is reviewing and including both well done and poorly done reviews, then the result it gives is not credible. So, but anyway, I'm reporting this accordingly, and they compare impact of multiple gardening interventions on different well-being contracts. So what they do, all right? So they use our 5 database to examine well-being, the variable they examine neighborhood cohesion, trust, social networking. The mental well-being variable they examine are depression, anxiety symptom, cognitive function. The quality of life variable they examine life satisfaction, independent living, health, etc. Right? So both gardening and HG were included. They found 40 study. Now they have 10 intervention study, 2 observation study, 28 mixed approaches, and their sample size include 200 something to 4,000 something. And so they include people with dementia, mental disorder, older adults, and they provide a narrative synthesis. So it's not a systematic analysis leading to a meta-synthesis, all right, to determine the overall impact, right? And then they report that those studies with quantitative data, they would report meta-analysis. So this is what they do. Now, what did they find? Okay, they reported that overall positive impact of gardening activities on mental health, quality of life, and health status have been found. Those studies that they can conduct meta-analysis show a significant and positive effect of gardening on well-being with an effect size of 0.55. Now, I want to discuss the term significant. In statistics, significant just mean, statistical significance. It doesn't mean that it is very important. It just means that statistically is significant. And then we have to look at these p-values, the figures, to determine how significant it is. The effect size 0.5, I'm not sure whether it's using a Cohen D effect size or other kinds of effect size, but 0.5 is pretty good. All right, I would say average. 1 effect size of 1 or more than 1 is very strong. Effect size of 0.2 or 0.1 is very small. So I would say it is average. And the high degree of heterogeneity in crew study cautions against any direct clinical implication of findings. So they even caution people reading their study about this. My appraisal is very problematic in combining different types of studies. As reported by the authors, many increased studies were of critically low quality. So this is problematic. Now, Liu et al., I want to introduce this very quickly, all right? So they want to review effect of HT on stress, okay, particularly look at stress. And this is the database they look at. They again include both quasi-experimental studies and RCTs, English or Chinese studies, and no restriction on the population or control group. And look at I'm sorry about the typo here, it's age, right? 7 to 93. So it is very variable, and the sample size can be 8 to 113. What did they report? Significant increased effect on psychological indicators compared to control group, insignificant on physiological indicators, stress-reducing effect related to characteristics of the population, particularly age over 60 and male. Here, look at this. Indoor and virtual areas were the most effective setting. A total of 100 to 500 minutes, that means 1.6 to 8 hours, provided better effects. So, well, my appraisal is that, well, this is a combination study, so affect the credibility of the finding. Only one included paper reported the use of virtual setting, and yet it's qualified as one of the most effective settings. I would say that they reported as having the highest impact. I would say it's the most effective. Unclear definition of HT, like they include walking, meditation, and whether the sole activity is outdoor walking in the park or whether walking is part of the HT program is unclear. So it's not very well done in my perspective, all right? The sample is heterogeneous. Now I want to talk a little bit about comparing RCT and quasi-experimental study. I already mentioned it earlier, but just to highlight the point, okay, so participant assignment is randomly assigned to the treatment or the control group. So it's non-random assignment, maybe just convenient. What is the meaning here? The meaning is that each participant is allocated to a group in an unbiased manner. So everyone has an equal chance of being assigned to either group, okay, either the experimental or the control group. So that would be sure of the finding. All right, so I provide a metaphor systematic review. I want to present a picture of a number of brackets of water, all over the place, but this is very hard for us to determine the effect. But if you want to study like same size bucket, okay, in the same place at the same height with the same diameter, then we analyze the content. Maybe it's easier for us to determine the final effect. And this is my study. This is my PhD study, okay? I just want to use it as an illustration. It is my study on the life storybook approach to improve the quality of life in nursing home residents with dementia. And I use a randomized control trial, single-blinded parallel groups design. I have one intervention group, I have one comparison group, and one no intervention group. And well, I interview staff later, but doesn't matter. Now, this is why a control condition, randomized control trial, is important in determining outcomes. All right. In my life storybook protocol, I have all these elements. My comparison group is a social activity group. So they talk about everything, social discussion regarding current topics, not related to personal life. An attempt made to prevent prevent and stop diversion the attention of participants when they start talking about their life events. So we divert them. All right. So everything is the same. The nature of the stimuli, the structure of the sessions, the member composition, the length, the frequency, the duration, the location, the staff attitude, and then the RN, how the process is being implemented and delivered, the outcome measure, the data collection raters, the time of measurement, everything is done in the same way. And the only difference is the content and the approach. So by doing so, I can comfortably discuss the result of my intervention can be attributed to the intervention, to the approach, and not being contaminated or affected by other parameters. Okay, so that is why a randomized control trial is very important. Now, two, on mental health. This study, I think I need to briefly mention just to illustrate how problematic a randomized control trial can be. All right, of course, they want to examine the effect of HT on mental health. So they used 4 databases, and then only RCTs with 19 trials, all right, sample 10 to 85, sample size 13 to 150, so multiple disease. And what they find is actually a significant positive effect on mental health, effect size medium, activities, okay, provide specific mental health problems through at least 8 consecutive sections would improve the outcome, all right. So here, my comment on 2 studies is that a systematic review or meta-analysis is not undertaken by a single researcher. It must at least have 2 persons. But this paper, the only researcher reported is 2. However, 2 reported that there was an independent reviewer working with him. So only in the discussion of the studies, selection of included study without other impact on other elements of this study. So I'm really doubtful. All right. Another problem of 2 is that what was being studied. All right. Okay, the final summary includes a total of 28 different measures. Do all the measure the same concept? And how did the author aggregate the scores? Because every measure, every endpoint have different width, all right? It can be 4 point, 5 point, 8 point. It can be dichotomous, like yes, no. So how is the score being compromised or being analyzed? Look at all the scores, all the measurement tools that's being included here. So personally speaking, I think it's very problematic. Okay, so I wouldn't go on any further. Though, if you're interested, you can look at my slides later. All right, and so I presented each and every one of them, and the next set of slides are about specific group, which is about people living with dementia, people are here, schizophrenia, all right, and then depression, okay, and then on older adults. Okay, so these are the few papers on older adults, and this is the paper on children, the only paper on school children. Okay, because of time, I have to go faster. I wouldn't read out to you or discuss each and every one of them. I want to go to the summary instead, all right? Now, these are the longitudinal studies. I think this is a worthwhile one to talk about because this talk about 11 years of examining the effect, gardening and mortality. So they want to test if gardening is beneficial for survival after adjusting for comorbidities, mobility, and depression in middle age, 50 to 64 years old and older cohorts in Taiwan. So this is a study from Taiwan, and I appreciate their study because the data set, when we clear 11-year longitudinal data set is very hard, all right? What they found, data home gardening was associated with a high survival rate. The benefits were robust, very strong for those with mobility limitation, but without depression at baseline. Chronic or relapsed depression weakened the protection of gardening. For those without mobility limitation and not depressed at baseline, gardening had no effect. Daily gardening for pleasure was associated with reduced mortality for Taiwanese over 50 years old with mobility limitations, but without depression. I couldn't comment. I have no particular comment. I think upon reading, I think it's quite well done, but then I would like a statistician I'm not a statistician myself, to look at the figures and the methodology used before I can fairly comment on the study. So to be fair, I'd rather not comment here, right? Now, this is another study that claimed to be, that is longitudinal in design. They only follow up in 1 year, all right? They only follow in 1 year, but still it is longitudinal design. And they found significant reduction in outpatient visit and inpatient psychiatric care in the rehab group. No significant difference in sick leave days in patients with severe stress or depression. Okay, so the overall picture, what do we find in the overall picture? Okay. In the general population part, gardening has small to medium effect on mental health. Overall, positive impact on mental health, quality of life, health status. Again, positive effect on well-being with meta-analysis. Significant improvement in stress, but not physical outcome. Indoor and virtual areas, most effective. 100 to 500 mini session better effect. Another study, significant effect on mental health with medium effect size, improvement with at least 8 sessions. Significant effect size for anxiety and depression, but not for well-being. Okay, HT may produce adverse consequence for some population. So this is interesting as well, Lassiter's study. Gardening improved mental well-being, increased physical activity, and reduction in social isolation. Moderate positive effect on HT, gardening on psychosocial well-being, greater effect size in individualistic culture, such as US, UK, than collectivistic culture like Hong Kong and Japan. A greater effect size was found in community gardening compared to horticultural intervention. And both studies report positive effects, none report negative effects. What about on people with dementia? What has people found? Positive impact on engagement, social interactions, and mental and physical well-being. No improvement for cognitive function. Lower agitation, increased engagement, less time of doing nothing. Decreased level of agitation. Okay, so this is what the impact of HT on people living with dementia. And this is on schizophrenia. Short-term effects, okay, moderate to large effect size on total symptom. Okay, better effects for patients with shorter durations of illness. Now, longer terms, more than 3 months, HT showed larger effect size for total symptoms and longer treatment with better outcomes. So HT is effective on symptom, rehab outcomes, social functioning in in-hospital and non-hospital environments, all right? Whereas non-hospital environment had better outcomes. And then on cognitive symptoms, now this is different, right? Significant improvement compared with the control group. On depression, study report improvement for depressive symptoms, all right? Generalizability finding is limited. So improved in depression, anxiety, cognitive function, social function, quality of life, but only one report improvement in physical function, okay? People with more severe symptoms have better outcomes, but certainty of evidence range from very low too low. Significant, again, the effect on depressive symptoms, different outcomes among various horticultural interventions, right? When they participate in the activities, they're more effective than just observing, like watching, okay, or whatever, meditation in parks, okay? Intervention of 4 to 8 weeks may be optimal compared to interventions to 8 weeks. Again, a controversy. Is it 8 weeks better? Is it longer better? Or 4 to 8 weeks is the optimal? Significant positive effects on positive outcomes and significant effect on one or more outcomes, but RCT conducted of relatively low quality. Okay. So what about older adults? May be helpful in helping seniors lose weight, okay, lower their stress and cortisol level, improve their social interaction, improve satisfaction, quality of life, cognition, social relationship, no negative events, and psychosocial well-being improved after HT, and causal relationship between improvement and HT, that's clear, okay? School children, okay? This is SGA, is school gardening activity. No obvious effect on improving the children's BMI and waist circumference, but they increase the children, if at the physical activity, they will increase children's food and vegetable intake, but not greatly improve weight status. So this is the outcome. Now, longitudinal design, we already talked about that, all right? So I'll skip that part. So overall, what have we learned about HT effects on human health? Most review report positive effects on various populations. Psychological benefits for people living with dementia, those with schizophrenia or depression, so improvement in behavioral symptoms and impact on cognitive function less obvious or not found. Most studies did not report any adverse events, and few review paper on other age groups except those on older adults, mental health patients, etc. What we do not know, what we do not know, how valid are these findings, summarizing the HT or gardening. Most study mixing RCTs and quasi-experimental studies and analysis. Many study a population with wide age range grouped together. Those who were well were grouped together with participants with confirmed diagnosis in meta-diagnosis. And some of study belong to diverse populations, some too small a sample for an RCT. 8 patients, not good enough, or 15, not good enough for RCT. And some outcomes being analyzed only for a couple of studies in the meta-analysis, and that is also not credible. So we don't know what is specific effect of HT, what caused the effect, and what elements would produce the most desirable effects. So these are still areas we need to look forward. So what is some concern about the current evidence? Unclear definition, conflicting result. Many review did not provide sufficient details about the design. Many samples are heterogeneous, and many different scales grouped together to represent a single outcome measure, say, for example, on mental health. And many included studies were not low quality. So is it virtual better than real life? Is non-hospital environment better or hospital environment better? Which duration is better? Is longer program better? Now, the newer evidence-based medicine pyramid, we used to be RCT on top, but now it is systematic review of RCT that are placed on top of this pyramid, because a systematic review of the RCT would be gauging the effect or the study credibility of RCT. So this is the latest medicine evidence-based pyramid, and you can look up in here, although I cannot share with you due to copyright reason. Now, one thing about systematic review is if you put in rubber garbage in, garbage out, if you put in poorly designed study into your systematic review and meta-analysis, your final outcome won't be nice. So what should we believe and what should we be moving forward? Okay, these are my questions, all right? Does the lack of robust evidence mean that HT has limited or doubtful effects? And I would say that perhaps we're asking the wrong question. Even if the effects of therapeutic horticulture therapy, gardening are short-lived, would it negate the value? Is it not just as worthwhile if the person felt relaxed, stress-free, focused, and functional at those particular moments while engaging in therapeutic horticulture? Even we don't see the long-term effect, wouldn't it just be as valuable? I would argue for the spiritual value of therapeutic horticulture because nature puts everything into perspective. If we go into the desert, if we go to the deepest water gulch, life always finds a way to forage against the elements. That is true even for tiny insects to towering trees. The resilience of nature persists. While engaging with nature, we become acutely aware of the connectedness of all beings in the world. And so, as part of this whole, we become more willing to let go of the matter that causes distress and of all the trivia in our daily life situation. And I can speak about this from my personal experience. And of course, the horticulture therapy and gardening about nurturing life. Activities of this nature is hard to come by in other therapeutic approaches. And so, of course, more rigorous studies are needed, and we also need to report adverse events that would enrich our therapeutic approach. And finally, the way forward as a person who is a non-therapist, right? But still, I think these are essential concepts that we need to consider. Thinking about AI and therapeutic horticulture. So I've asked this question a couple of times. Okay, is simulation or virtual reality better than real life? Can AI replace a horticultural therapist? If you need to use AI as a horticultural therapist, in what way would you engage the technology? Right, this is coming to affect all aspects of healthcare service delivery. About partnership, who are our partners, collaborators, landscape architects, farming experts, agriculturalists, botanists, kinesiologists, engineers, computing scientists, who will be our collaborators? And then advocacy. I think Nordic countries have incorporated tea into formal treatment programs. I'm not sure about the UK. Maybe you can share with me your wisdom and insight, and how can we promote this around the world? My final message is that HT or therapeutic horticulture has therapeutic effect in both general and specific population, and seem to be particularly useful in helping people with psychosocial issues. Their effect or efficacy mainly tested in older adults and patients with mental health problems. There's a lot to be done in the use and development of therapeutic horticulture for health promotion, and we need solid evidence. Good science is hard work, but only with convincing evidence can therapists advocate for its wider use, and with stronger evidence, we can promote HT as an intervention modality, and we'll be able to gather public support for funding and policy advancement. So I suggest that, and I hope that therapies will foster a network and collaboration across multiple disciplines. And that would be all for my presentation. These are my references, and thank you. I'm just acknowledging my other affiliation, just to be respectful to my other affiliations. Thank you. So our discussion?
Thank you, Claudia. Wow. Thank you for that tour, slightly breathless tour of a vast research pool, and the good, the bad, and the ugly, and for considering each element so carefully. I must admit, I feel slightly confronted or horrified by your point about AI, but you're absolutely right. We should consider it because it's coming. It's affecting every domain, and I think I smugly kind of assume that both the therapeutic side and the horticultural side of our world can't really be replaced by AI, but possibly that's too smug and too complacent, and we must think about what's coming and how it might affect us.
Share a few
And Joe, now
experiences.
just
I joined I was at the conference on horticulture therapy organized by the Harbin Institute of Technology in China. And I have come across many presentations that researchers in China are using technology in delivering intervention. They use virtual realities. They scale up images as if they are in the real life. So they wear those goggles and deliver to students. So they look at those images and then they measure their stress level. In fact, it's been already being used, but they're using technology, but not AI yet, because when we talk about using AI, we're talking about learning and responding to questions and then improving themselves or directly interacting with you. So they're using technology for sure, but I presume that maybe the next level that they will be doing. And I'm sure there's only more than China that's doing this, there may be other countries as well.
well, fascinating. Yeah, I think for sure, the famous studies of the hospital window views by Dr. Roger Ulrich went on to look at paintings or images of nature and compare them with abstract and man-made images, and certainly just looking at nature in some form, whether that's a technological or computer-generated image, or a painted one, it certainly was better than an abstract or a man-made image. So that does resonate, of course, and those are much older studies before AI was really a thing. But we often talk about therapeutic horticulture, gardening being an antidote to screen time and the lure of artificial light and technology. So it's really interesting because it's here and we're kind of denying it or not looking at it, but it's also it's antithetical in a way, but we need to maybe take a different view. I'm going to stop talking and let Joe see if there are any questions. I can see there's one already.
Thank you. Yeah, that was really, really interesting. Some really striking things that came out of it. So there's a couple of comments here from Liz just saying amazing. Thank you so much for such a valuable presentation. And Leanne has made a comment about AI. AI HTs is an off-putting concept to me. I really appreciate your presentation. I didn't realize so many studies were not of good quality. And I think, yeah, I would probably echo that. Maybe I know we're aware that there's lots that that aren't great, but yes, I think we maybe feel there are, yeah, it's surprising maybe that you found so many that just didn't cut it, if you like. I don't know
Okay.
your
Joe, if you can turn your volume a bit louder, it'd be easy for me to hear. I see that comment too, but I'm not going to say that therapeutic horticulture is not valuable because of the low quality. I think many of us here in this group are aware of the therapeutic nature when we're within nature, when we're in the outdoor setting. I'm not a horticultural therapist, but I'm a hiker. So I try to hike every week. At least I try, right, every week. So whenever I'm in nature, I just feel the power of healing. And that, including a lot of anecdotal evidence provided by people, I think it is really amazing that how nature can heal us, or how working in the garden, how engaging with plants, nurturing plants, etc., can heal us. And I do believe that. So even though they are of low quality, and it's not easy to conduct a study, so I'm very sympathetic to those researchers. And it's terribly expensive to conduct a randomized control trial. It's very expensive. You consider you have to pay for all this element to control all the characteristics. And so although they have low quality, and there are some that are of high quality, so that each and every one that we go through, they report a positive result. So although we can put some question mark into really how big the effect size is, they all speak the same language. They all report the same finding, positive outcomes of some level, particularly for psychosocial issues. So I think that part we can be quite sure about. What we cannot be sure is like whether cognition can be improved, all right, or whether physical health can be improved. That part, I think we still need a lot more study. But its impact on stress reduction, on psychosocial issues, I think that is a pretty extensive evidence. So I'm more positive about that. I'm more optimistic about how we can claim that therapeutic horticulture can help that area for people who need that kind of support.
Thank you, Claudia. Sorry, my computer's a little bit difficult with
Oh,
sound.
no worries,
No,
no
no, it's
worries.
okay. Does anyone have any questions that they want to, raise their hand and actually just ask Claudia out loud in the group? Nope, the takers. Oh, yeah, I've got to carry on. Claudia.
Hi, Claudia, me again.
Uh-huh.
I know you mentioned cost. I know that funding is really tricky to get for these studies, and I know that we're complex human beings, and there's so many factors in our lives that it's really hard to isolate the effect of the therapeutic gardening intervention. But that's the job of researchers, to isolate those factors and try to get to the bottom of the mechanisms. So beyond funding and the complexity, why do you think so many studies are flawed and inadequate? Um, researchers know that they should be aiming for, a certain quality, and if they have an interest in this field, they know that it's complex to measure. So what other factors do you think are getting in the way of better research, and how can that guide us to work with university partners in the future to try and study this?
Thank you for the question. Well, I would propose, personally, I intend to propose, but then okay. Because therapeutic horticulture, the course that I took, and then also the program that my fellow therapists I work with, include too many different elements. So where they grow plants, they use the flowers to build a collage, and then or to make a picture frame, or then make a flower arrangement, or cook and eat the food. All of these are part of the program for horticulture. But if we are to identify what would cause the positive effect, I think each of these would need to be isolated. Because as a researcher, I can easily argue, no, it's not. It's the social interaction, because within the group, you have lots of people. So everybody is joining in. The social interaction promote the sense of well-being. Or it is the occupational therapy that helps. So it is very hard if you if we do not isolate particular elements and then study as an integrate whole. For me, I would argue that the most, I've argued it before, but I'm going to argue it again. The most special element about therapeutic horticulture is engaging people with living, growing things. So this is not comparable in any other activities. So yeah, social gathering may promote well-being. All right, getting together to produce something may promote a sense of self-efficacy. If I can produce a flower arrangement, if I can produce a collage, that may give me a sense of achievement. The self-efficacy would be tested as higher post-intervention. But if we are to do research, like we need to have various groups, okay? One group with social interaction being controlled, one group with like the eating part being controlled, and then other part is just manipulating, nurturing living things. So in terms of doing a rigorous research, you will need to have multiple groups. And it's not just funding, it's also recruitment. Okay. So how do you recruit sufficient sample size? If you have 3 groups, you isolate 3 or 4 groups. Each group should be of comparable sample size, and then you randomly allocate them to each group. So that is also dependent upon the willingness of the participant to cooperate. So yeah, but then I think one step at a time. We can go one step at a time.
Thanks, Claudia.
Thanks. Really interesting. And about separating it out in the program. Yeah, we make a program diverse so that it can accommodate different weather, different people's interests and activities, and vary it with the seasons. But you're right, to study it, you will probably need to have a much more striated or separated out design of study to look at each of those components, because they're just blurring together, aren't they?
Well, I see Leanne make a comment, what we can do to contribute to this research. Sometimes, Leanne maybe probably differentiate the program into different segments, all right? So in this segment is purely about living things. The subsequent segment is about other elements being incorporated, like making a flower arrangement or cutting suits, okay, or developing new suits, whatever. So working with the researcher, maybe, because sometimes I feel the sense of the therapist not willing to differentiate different components within the program. So that's one thing that I can suggest. And then there's also one comment by Lise. Lise, I'm totally with you. How can AI replace human? All right, so I think it can never replace human, but sometimes people would choose the easier way out. For example, I don't know whether you have heard when I asked to talk about AI and technology on care of older adults, so I did some searches and I found a story that people fall in love with their AI agent. They marry their AI agent. And then, so you purchase a program, your AI agent can have only how many bytes or units are, right? The bytes, the units are up. So the relationship had to terminate. And that's one story. That's a real story I can show you if you want. This man cried, right? And then this man are not without wives or girlfriend. So this is, I don't know what to say. I don't think AI can replace human, but there might be a situation that some researchers or interventionists would like to see how it can be used, because we simply do not have enough therapists, right? Or simply the wave of AI invading, or I won't say invade, is critique, right? Right, impounding on us from all aspects of life. So maybe some people may be interested in building an interactive program on top of what the technology, the simulation that they have now, they want to make it into more interactive, then they will be using AI. So there may be some situations, but I do believe eventually the therapist or the interventionist would have the power of discernment to identify situations and make decisions on site that are suitable for the other party. So right now, what we are better as a human being is the critical analysis, the discernment, which the creative thinking is not AI can compare as yet.
A very long running debate, this one. Collins made the comment, the most interesting aspect of your talk is the benefit of if horticultural therapy at the time expect a longer lasting effect after the event. Those with traumatic problems are finding an immediate effect, but also longer lasting. And yeah, that I was surprised at that as well, that there wasn't.
Hi, Colin. Thank you for your comment. I have no response to that because I don't understand that either. And I have very limited exploration on traumatic problems like post-traumatic stress injury or other aspects of trauma, like dysfunctional grieving, for example. So I really don't know. And I think we have very limited result because there are very limited longitudinal studies or studies with longitudinal design to examine the proper outcomes or efficacy studies. But I think that certainly is a very good question that deserves our attention.
Do you not find that with your own hiking, that you feel so in touch with nature at the time, but then there is a longer term effect when you get back home?
Well, yeah, I think that can be true too. It's only that we have to find ways to measure it. You're perfectly right.
Yes.
Yeah.
Well, yeah, there is one study that's fairly robust from Gonzalez et al. I think it's Norway-based study. They followed up after 3 months and found a remaining sustainable, lasting effect on patients with clinical depression who'd had a therapeutic horticulture intervention. So there was a 3-month lasting effect there. Yes, we do think it lasts, but the research doesn't necessarily show it so far. But we're making an argument with health policy, government health people and funders here in Scotland that almost uniquely therapeutic horticulture interventions have a really high adherence rate. People stick to this because of nature's changing and they enjoy it. Gardening's already a really popular hobby, one of the most popular in the UK. So people tend to stick with it, which is not the case with many prescriptions and interventions. And so they are likely to then have the best effect because they stick to it, they don't give up. And then quite often they adopt part of that into their lives afterwards. So they keep on gardening, or they find a community garden they want to volunteer at, or they nurture some balcony plants or some house plants. So we make that argument, but it's not currently strongly backed up by research of this lasting effect.
I would love to read that paper. One thing I've noticed in my several studies that therapeutic horticulture is not necessarily for everyone. I come across ladies that we have accessed or try to approach. Then she just doesn't like it. We explained to her during the recruitment, she just don't want to. All right. And then there are other incidents that a patient become very sad because of the plant died. Right. So these have not been reported at all. And this needs to be reported because there may be very few, but still we need to include them and report them and share them so that we can develop a better practice guideline. Yeah. And also it's not just probably for the person who is at the receiving end. And I also have once a patient in a hospice care unit patient engaged in horticultural therapy, and then he later passed away. And the family come back and ask us for the flower arrangement that he did. And so that we thought of talking about examining the impact on the family caregiver. There's also an area that can be interesting to look at. Or of course, we cannot give that flower arrangement because I guess that's been disposed of and it won't last that long, right? But we do share the picture of the flower arrangement. So, and then of course, in situation like this, the family may become very disappointed or disillusioned, etc. So these are the things that I never come across it in reading. So I think we need to share that as well.
Yeah.
A slight publication bias in
yes,
therapeutic horticulture as well.
Yeah, indeed.
Thank you, Claudia. Claudia. Yeah.
Do you think we have any other comments or questions?
No.
I'm very sorry though that my slides are pretty flat and wordy, and I do not have pictures like the therapists do. I noticed that your presentation are full of lovely pictures of nature, and I don't have space to incorporate them. And then yeah, sorry.
That's okay, but we need you to have a clear focus on the stats and the trends that are arising from those and be analytic, you know, because we do all the photos thing, but if we only do that, we never get beyond our current practice today, and we don't develop.
Another topic that on researcher and can think of, you can study with kinesiologists or engineers looking at the dexterity. So in rehabilitation, so when you're engaging a patient with traumatic brain injury or any kind of injury, post surgery or post etc. post the accident, and then look at how horticultural therapy, when engaging the hand and fingers, would improve dexterity. I think that's also interesting.
Yeah, and we have physiotherapists talking about using the garden and finding that people are more amenable to doing their physio movements because they're wrapped up in a meaningful and joyful activity of gardening. They're not just doing the exercises repetitively. So yeah, it's a really fruitful area to think about. I'm going to have to wrap us up, I think, because we're over time, and I know we could talk all day about research in this area. So it's been fascinating, Claudia. Thank you so much. I would just invite everyone to show their reaction. I know some people already have in the chat, but if you want to use the reaction button at the bottom there and show your appreciation with some applause or whatever.